Series, and this is going to be the chapter 14, acquired macular diseases, part 11. And this part we are going to discuss about the solar retinopathy. Solar retinopathy pathogenesis include the retinal injury result from the photochemical effect of the solar radiation after directly or indirectly viewing the sun. So basically, after the sun exposure, there are certain kind of solar radiations that, if affect the retina, can cause the retinal injury. Presentation is within a few hours of exposure with impairment of central vision and a small central scotoma. So there will be the impairment of the central vision, and there can be the small central scotoma. So signs will be visual acuity is variable according to severity. A small yellow or red foveolar spot that fades within a few weeks. The spot evolves to a sharply defined foveolar defect with irregular borders or a lamellar hole. So let's see figure 14.62. So this is a solar retinopathy, solar and laser induced maculopathy. A is showing us a solar induced yellow foveolar spot. So this is a foveolar spot which is yellow in color. B is showing solar induced foveolar defect. C is showing the fluorescent autofluorescence showing a focal laser injury. So you can see that there is an injury to the fovea due to laser. And D is showing the OCT of C showing the intraretinal cavitation and disruption to the RPE in the acute phase. So you can see that there is a disruption in the RPE phase and there is an intraretinal cavitation. So OCT show the foveal thinning with focal hyporeflective area, the depth of which correlates with the extent of visual acuity loss, but which generally includes the photoreceptor inner and outer segment. So basically OCT have a foveal thinning and it have a focal hyporeflective area. And so how much depth of it is, the focal hyporeflective area will correlate with the visual acuity, and it also generally include the photoreceptor inner segment outer segment junction. So treatment is usually not available. Prognosis is good in most cases with the improvement of visual acuity to normal or near normal levels within 6 months. In a minority, significant reduced vision persists. So basically you just observe this lesion, and mostly the prognosis is good with the visual acuity return to normal or near normal within 6 months. Differential diagnosis include macular damage that is similar in appearance may occur as a consequence of a laser injury induced accidentally or by staring a laser pointer. So it can also be caused due to the laser injury. So it is one of the differential diagnosis of the uh, solar retinopathy is a laser injury. Next is a focal choroidal excavation. So focal choroidal excavation FCE is a recently described relatively common condition in which one or more areas of macular choroidal excavation are detected in one or both eyes of a patient, typically middle age and possibly more commonly Eastern Asian without a history of ocular disease known to produce the choroidal thinning. So basically it is typically present in a middle age patient, especially Eastern Asian, and it can affect one eye or both eyes, and it can be have involved the multiple choroidal excavation area. Visual acuity is variably affected and may be compromised by complications such as CNV, CSR, and PCV. So visual acuity basically can be have a problem if there is a complications such as CNV, choroidal neovascularization, central serous retinopathy, and PCV. Overlying pigment epithelial disturbance or a small yellowish white deposit, sometimes vitelliform, are often seen clinically. On OCT in conforming FCE, the overlying RPE and inner segment outer segment junction follow the outward indentation of the excavation. So excavation is basically the photoreceptor and the RPE layer will follow this excavation. By contrast, in non-conforming FCE, the photoreceptor layer are disrupted and appears to be separated from the RPE. So in a cases of a non-conforming FCE, the photoreceptor layer is disrupted and appears to be separated from RPE. So let's see figure 14.63, focal choroidal excavation. A is showing OCT of conforming type and B is showing OCT of a non-conforming type. And this is a 14.64. It is showing OCT of a dome-shaped maculopathy. A is showing us a horizontal scan and B is showing us a vertical scan. So there is a dome-shaped excavation of the macula. It is a dome-shaped macula. This is a rare condition seen in a myopic adult. Approximately half are highly myopic and half the condition involve both eyes. So it usually involves the myopic people. Patient present with impaired vision and no other signs of ocular disease. The cause is not known, but the condition may represent a type of a localized staphyloma. The diagnosis is made on OCT analysis, where a serious macular detachment is often found. The key to diagnosis is to undertake visual, vertical, and horizontal linear OCT scan, as the ridge may be visible in one meridian. In approximately 25%, the subretinal fluid disappears spontaneously in time. This is not treatment. In particular, anti-VEGF agent injections have no effect. The vision usually does not usually deteriorate despite the OCT appearance. So basically, it is a type of a condition in which basically occur in a case of a myopic eye. There is a slightly dome-shaped macula, and sometimes there is a serious macular detachment that is present, and generally there is no treatment is required for these cases. Next is a low visual aid. So, in a case of any macular problem, when the macula cannot be healed, then there are certain instruments that we can use to improve the vision of the patient. Low visual aids is one of the helpful aids to increase the vision in a macular pathology. Part of the effective management of the patient with poor vision as a consequence of a bilateral macular disease is the use of low visual aids. Skilled instruction on their use is key to their successful implementation. All aids are based on simple magnification and good illumination. There are 5 basic types of a low visual aids. Non-optical device adaptive aid, such as large print talking clocks and fluid level indicators. So there are non-optical devices like you can use, which are adaptive aids, which consist of the if the we use the books which have a large prints, we can take a non-talking clocks and fluid level indicators. Next is the tints and filters. So gray lenses reduce the light intensity and yellow lenses improve contrast. So sometimes you can use tints and filters. So the gray lenses can reduce the light intensity and the yellow lenses improve the contrast. An anti-reflective coating on spectacle can be used to reduce glares. Convex lens aids such as magnifiers are used for most patients. Handheld magnifiers are often helpful, particularly if the illumination is good. The main advantage of the spectacle mounted and a dome magnifier is that both hands are free. A focused image is always produced at a set distance, but the amount of magnification is limited and the distortion at the edge may occur. So basically with the convex lens aid, sometimes with a handheld magnifier, what you can do is you can use this handheld magnifier and uh, make the words basically enlarge, and they magnify the image and you can see the image better. So sometimes it is handheld and sometimes it is spectacle mounted or dome magnifier, which in which the hands are free. Then there are telescopes which can be used. These can be focused from distance to near but have the disadvantage of small and shallow visual field. So you can also use telescope, but the visual field is small and shallow. Electronic devices and portable video magnifiers such as reading machines, image scanner, and closed circuit televisions. These options are expensive but allow significant magnification from 1.5x to 45x with adjustable font size. So you can also use some electronic device and portable magnifiers as well, for reading machines, for uh, image such as image scanners, closed circuit televisions, to improve the magnification of an anything. So this is a low visual aid. A is showing us a illuminated magnifying light. B is showing us a pocket magnifier. So this is a pocket magnifier. C is showing us a portable video magnifier. So that's it for the part 11. See you in the next lecture.